Welcome to the Learn Skin podcast with Dr. Raja and Dr. Hadar, where they discuss all things skin. Skin is fascinating because it affects us in so many ways, like our health, psychology, and how we connect with those around us. This podcast delves into the art and science of skincare. A short disclaimer before we get to the good stuff. Dr. Raja Sivamani and Dr. Hadar Levtov are board-certified dermatologists. This podcast is meant for educational and informational purposes only. All opinions shared do not express the views of Learn Skin. Neither this podcast nor any information contained within it are a substitute for professional care by a doctor or other qualified medical professional. This podcast does not constitute medical or other professional advice or services. If you have a medical concern, please consult with your physician.
Welcome, Learn Skin podcast here with Raja Sivamani and Hadar Levtov. We are talking skin cancer screening. I know This is a big topic that we talk about frequently.
Yes, absolutely.
There's a few nuances in there, but Hadar, let's start with this task force recommendation. I know that there's a recommendation around skin cancer screening. If you don't mind telling us a little bit about what is that recommendation. Let's talk about what's practical. How do we approach it?
Yes, so I think it's important that people realize the U.S. task force looks at summation of all the evidence that's available for a certain screening or preventative action that physicians can do to prevent disease. And in this case, they looked at skin exams by physicians and dermatologists to prevent skin cancers, specifically, I think it was melanoma. And they came up with the recommendation that the category is I, meaning that there's insufficient evidence. And so they determined there's insufficient evidence to recommend for people, and that's the general population, to go and see a dermatologist or a doctor, let's say annually or routinely for skin cancer exam to try to detect melanoma. But I think it's important to understand that, first of all, this was not well received, at least in the dermatologist community, because we see this daily, that dermatologists find incidentally melanomas routinely. A patient comes in for a pimple, leaves with an excision of a melanoma, and it's not an uncommon story. So we know this. And so I think the key thing to take from that recommendation is that there's insufficient evidence. But if you have patients, or if you are a listener who's a person and have a spot on your skin that you're not sure what to do about, or it's changing or anything like that, you should go to a qualified dermatologist to look at your skin and evaluate this, because these people have spent significant amount of time of their lives just focusing on how to distinguish what's dangerous and what's not.
Yeah, and I think the task force is important just to say every single all-comer, we still need a bit more studies on, where are we thinking about the impact of skin cancer. But we know that if you have a weird-looking mole, as we say, quote, weird-looking mole, then I think it is really important to get someone that just looks at nevi all day long to understand. And there's a funny thing, we use this ABCD rule, but when you walk into a dermatologist's office, we don't just use an ABCD rule, even the ABCDE rule, A asymmetry, B border, C color, D diameter greater than 6 millimeters, and E evolution. We actually use an ugly duckling rule too, where if you come in with a weird looking mole, we don't determine what's weird until we actually look at the summation of the person, and their skin exam becomes super crucial. And I think you can't just use the task force and say, the task force said I shouldn't do full skin exams. Well, that goes out the window when you have someone coming in asking specifically, saying, hey, doc, this doesn't look right to me, or I don't even know if it looks right because I can't see the spot on my back. Then I think you really have to take a full look at their skin to make an assessment. I can't tell you how many times, and I'm sure it's come up to you, where something just doesn't look right and ends up being a melanoma. And I've been humbled so many times in my career that I try not to be arrogant about that.
And you're absolutely 100% right. And you mentioned a few things that I want to touch upon. First of all, amelanotic melanoma, and Spitz nevi and such. You pick those up. And that's scary, and there's no way a person, and even a physician who's not trained, can pick those up. Those are the nightmare lesions for trained dermatologists.
Even for dermatologists.
So to kind of suggest that, anybody can pick this up. And then the ABCDE, which I think is an important tool, but just to keep this in context, this was devised as a mnemonic tool for medical students to remember the answer on a test. It was never meant as a public safety measure. And as a it's my personal bias that as a tool to communicate to the public, it's awful. Who in the public can remember 5 different things? I think it's a call for dermatologists to come together and say, hey, we need a better tool. I think it all boils down to asymmetry. And that's the one thing I tell my patients. If you can remember, one thing is asymmetry, or something is unusual. It grows too fast. There's asymmetry in the size and the color and the texture. One side was white, now is black. One was black, now it's white. Things are changing. There's asymmetry. There's asymmetry in the evolution. That's what I talk to about my patients, because I think that's something they can walk away from. So, and then there's no question that when it comes to so this was talking about primary prevention, but when you talk about secondary prevention, looking at people at risk, there's no question that they need more sort of regimen of screening and regular intervals to identify any evolving lesions or lesions that are at risk. People who have history of melanoma or other skin cancers, people who have a very strong family history, people who are immunosuppressed, and that population is rapidly increasing. I see them more and more every day, people who had transplants and are on various immunosuppressive medications. So we have to remember that this is slowly becoming a big chunk of our population, especially as people are aging, and they're inevitably going to have history of skin cancer because it's the most common cancer. So I think we should take this recommendation with a grain of salt and be more practical when we approach it.
Yeah, thanks for touching on this. The fact that I think the ABCD rule is something I definitely talk to my patients about it, because I think it's a good mnemonic. But at the end of the day, I agree with you that asymmetry is number one. And if something's new and you're not sure, definitely have someone look at it. And a dermatologist, we have so many different practitioners that are available and that can look at the skin lesions, but really when it comes down to something unusual, a dermatologist has just had so many hours and hours, countless hours of looking at these lesions, that you want to be sure that you have someone that's well trained at looking at these lesions, looking at them, because again, even for dermatologists, it can be a challenging scenario, and the way you do the biopsy is really important. You don't want to do partial biopsies. You want to make sure you get the full sample, and that can change management, down the line.
Yes, and people freezing the wrong lesion, and then you have artifact, and on and on. I can't tell you how many complaints I hear from pathologists who don't, they're not going to bring it up, but because they feel uncomfortable, there's other people doing biopsies. And certainly we want people to be engaged and be aware of the need for taking care of skin. But if you biopsy a lesion the wrong way, there are implications down the line for the patient, all the way to staging of disease. And so you have to be aware of how you're going to biopsy the lesion. And I also want to say that we talk about sunscreen and the need for training. Recently, especially the new generation of dermatologists are all trained to use dermoscopy, which on top of all the tools that we mentioned, the ugly duckling signs and looking at ABCDEs, which dermatologists do as well. And then you add on top of it the use of dermoscopy and even some other advanced tools, which we discussed in a separate podcast. Those really make dermatologists super well poised to pick up those lesions to the best that the human eye can do. So I think there's no question that if you're going to do this, do it the right way. And if something is changing on your skin, go see a dermatologist. It's that simple. All right, but I do think we wanted to also talk about some practical points here for skin exam, because, okay, a patient walks into your clinic, and a question I get a lot from my residents and from other dermatologists is, do you do a skin exam, a full skin exam on all your patients day one when you just meet them? So this is a topic that is always interesting, and I always want to hear people's perspectives on this. There's no right answer, obviously. Everybody has their own style, but I'll let you, Raja, go ahead and kick this off.
Well, my knee-jerk answer when I first heard this conversation was like, well, obviously that's a yes. But then I started thinking a little bit more about it, and I started realizing it does depend. My personal utopian situation would be just because we've caught incidental things on people. They'll come in for one thing and say, my eyelashes are falling out or something, and then you find some funny-looking lesion somewhere else, and it turns out to be a skin cancer. And so, in a utopian world, I would say, yes, do a full skin exam on everyone. But I think, you have to take it into context. And I've learned along the way that sometimes a patient isn't ready for a full skin exam when they come in, primarily because they're trying to find the first dermatologist. And sometimes, I get orthodox patients that are women. And for them, they may not even bring up the fact that, hey, it's uncomfortable to do a full skin exam. And I feel like I need to be culturally sensitive about that and not push it. And so, I try to read the patient, and I've changed the stance to say that, we want to get a full skin exam. And if now is appropriate and we feel like it's the right setting, let's do it. But if there's a scenario where there clearly is some reasons for why maybe I'm not the right person to do a full skin exam, I'm quick to talk about it and then move them to a colleague that might be a better fit, in case of an orthodox patient. Maybe a woman should be doing the full skin exam because I don't want to put that patient in an uncomfortable position.
Right. And I think we should, so there's a few biases I want to mention. One, we're talking about in the United States where dermatologists are available. And if you need a female dermatologist, you can get it. If we were in some place where you're the only dermatologist for miles and miles, maybe that we would need to look at it differently.
That's a good point.
For everything I'm going to say is the one caveat I have is that you should not forgo a full skin exam for the reason of no time. I think dermatologists, that's mainly the reason. If we're putting things on the table, it's a cop-out. People say, I'm not going to do it today because A, B, and C, and D, but really it's because they don't have time. So if you're not going to do this, that's fine. Just acknowledge you don't have time for this today. We'll do it in 2 weeks when you come back. That's fine, but just be straight up about that. With that in mind, my bias.
Can I make a comment on that?
Sure,
One thing that I can say is in regards to that, I think sometimes if a patient isn't ready for a full skin exam, it takes them a while to get undressed, and they sometimes have like 30 layers on or whatnot. And sometimes it can take a significant amount of time. So if you're going to see the dermatologist, my number one suggestion is dress to undress quickly.
Yes.
If you're thinking of going to a dermatologist, and sometimes it doesn't work out because they have other life things that are going on. And in some scenarios, I have had patients say, hey, I can't do it right now and I want to come back because they're going to something, and undressing can become a little bit.
And that's why I love practicing in Florida as opposed to New York, because everybody came in with coats, and it would take them a long time. And that's one of the things you have to establish with your staff to make sure that if you're the kind of a person who wants to do full skin checks, you got to keep that. You got to let your staff know so they get your patients undressed and ready. But I want to say this, my default is to get a full skin exam on all patients because I do think it's good medicine. I always say, you don't auscultate one lung. And so you don't just look at the face. And that's true for everything that we do in dermatology, because the patients come in and they have their own bias. They don't know that their rash necessarily could affect the rest of their body. And same goes for a skin exam screening. And we pick up about the disease from the entire skin, including looking inside the mouth and looking at nails and looking at hair. And so we get clues from everything. And that's true also for skin exams. So I can't tell you how many times I do this and patients actually thank me. One thing that also I find is that when I insist on doing it like that, I'll walk into the room and the patient is in a gown and undressed, but they keep their socks on. And so
it's cold in the room. It's cold in the room.
It may be cold in the room, but I do take note of that. And then I don't tell them anything about that. And I start the visit and we go through the exam. And then towards the end, when we kind of made that relationship and maybe gained some trust, hopefully, then I'll suggest, hey, can I take a look at your feet? And, it happens every now and then that they'll say, I'm really uncomfortable about my feet. And I say, why? And they say, well, I have this rash or my nails are ugly. And then we say, hey, it's just tinnitus. We can take care of this. I know how to do this. And boom, it's a win. And everybody's happy. And actually, I helped them with something that they were embarrassed about for maybe years. So I do find that there's so many added benefits to this, and it boils down to really good medicine. Now, all the caveats that were mentioned before are absolutely true. And if I feel, I agree with you 100% when you say that about being culturally sensitive to people who may not even say it. You have a woman who look like she is religious and Orthodox, or even a man, and don't feel comfortable undressing. You should pick up that cue and engage them in the conversation, and don't wait for them to say something, because a lot of times they will not. And just tell them, look, I want you to know it's important. And even if now is not the right time, we can set up the right time and right environment that you feel comfortable to take care of your health. It's good medicine.
Yeah, one of the things when talking to people about full skin exams that I find helpful, especially examining the feet, and I have a lot of folks that continue to wear their socks. I found that that's more common in the wintertime because it's a little cold.
Sure,
I do remind them that, we have famous folks like Bob Marley who have had acral melanomas, and that sometimes skin cancers can occur in places where the sun doesn't necessarily classically shine. But
great point.
I think it's important to realize that some of these skin cancers aren't dependent on sun exposure. And once I mention that, they're happy to take their socks off usually. The second thing, and this is something that I've learned just growing up in a community where, there's a lot of orthodox rules and whatnot, just, in my upbringing, sometimes people won't tell you that's the reason. And the American way is to ask people and have them reply. But that doesn't always work in some cultures. You can't just say, "Oh, are you uncomfortable?" Because that in and of itself is uncomfortable, and they won't tell you that they're uncomfortable. Sometimes they may even feel coerced in that position. So it's a fine line, and sometimes you have to read the situation. And then another thing is I usually have scribes in the room and whatnot, but sometimes, patients get uncomfortable with that too. I think it's always important to have a chaperone in the room as a physician, but I think just that part you have to acknowledge that, hey, this person is here in the room with me. It's to, help document. And I try to make it a point to introduce the person in the room with me. So it's not some foreign entity, kind of like a voyeuristic look at the skin exam, so that everybody feels comfortable in the room.
Right. And I think we gave a good perspective, and I'm curious to know what other people are doing. So certainly feel free to comment on our Facebook page. What is your approach and why? What are your pros and cons for doing this? Like we said in the beginning, there's no right answer. And as long as you are communicating with your patients and you make sure that they're taken care of for whatever their medical need is, then you're probably doing the right thing.
Yeah, I think this is a great way to, wrap up our conversation here. Comment on our group and check out our podcast, and, tell us what you do for your skin cancer screening. And thanks for talking about this, Hadar.
Yeah, thanks, Raja.
Thank you for tuning in with Dr. Raja and Dr. Hadar. This podcast is brought to you by Learn Skin, leaders in integrative dermatology education. Visit learnskin.com/podcast to explore our many programs. Subscribe today and never miss an episode.